Okay, within the minute or two in the right time here. I'm Bev Temple from University of Manitoba, the College of Nursing, and I want to welcome everybody to the WebEx for the KT Canada today. A bit of housekeeping. We will have questions happen at the end, but you can also put them into your chat, and if they go directly to Megan Story, who is hosting in Toronto, then she will send them on as well to me, but I will also just ask for questions at the end as well from all the different sites. So if there's no major questions right now and I haven't seen anything come back to me, then I would just start with introducing our speaker today, and thanks, Terry, for agreeing to do this. Dr. Klassen is the Director of Translating Emergency Knowledge for Kids, TREKK, and the CEO for the Children's Hospital Research Institute of Manitoba. He's also head of the Department of Pediatrics and Child Health in the Faculty of Klassen at the University of Manitoba, and director of the George and Fay Yee Center for Healthcare Innovation. He is a clinical scientist whose clinical base is pediatric emergency medicine with research expertise in randomized control trials, systematic reviews, and knowledge translation. So welcome, and I pass it to you, Terry.
Well, thank you much, and hello to everyone out there. And I also have a local group here in Winnipeg that's sitting in the room. It's great to be invited to talk to what I think is a very exciting project, Translating Emergency Knowledge for Kids. The timing of this is incredible because next Tuesday we have to go to Ottawa. So we've had 4 years from the Network Centers of Excellence Knowledge and Mobilization Initiative, and that will come to a close at the end of this year. The meeting in Ottawa is we have to make a presentation to the panel to convince them that we need another 3 years of funding to accomplish the goals of TREKK. So the timing of this is incredible. So I know I've talked about TREKK in some KT Canada venue a little over a year ago in Quebec City. But just to review that, TREKK really had 3 objectives. One was to determine the needs of end users. We wanted to design and create resources to answer those needs. And we really want to connect with stakeholders across the country to form a network that was effective and really assisting and making sure that the knowledge mobilization was happening. But why? Well, consider that 85% of Canadian children who need emergency care are actually treated in general emergency departments that are not a part of children's hospitals. And yet most of the research is happening in the pediatric emergency hospital. So there's a risk that research remains in that pediatric hospital and never benefits the vast majority of kids who need it. We have some data to suggest that 40% of children do not receive treatments where clear evidence exists within that broader context, and 1 in 5 might actually get treatment for which there's no benefit. It might be harmful at times. Why might that be, and why TREKK? Well, we know there are barriers that in terms of providing pediatric emergency care for EDs that do not have a pediatric focus. The vast majority of your patients are adults. You not always have the access to appropriate training. You might have difficulty getting the resources to assist in providing the care you'd like to. And I think this has the real risk of providing extremely variable level of pediatric emergency care across Canada. The vision of TREKK really was that every child receives the highest standard of care, whether they seek treatment in a pediatric or an emergency department. And so to accomplish this vision, we had 3 phases to our plan in the first 4 years of funding. The needs assessment, mapping the current evidence, and sharing this knowledge and using practical tools and innovative tools to really accomplish that goal. So what is PERK, or Pediatric Emergency Research of Canada? It was a group that was established in 1995. Pediatric emergency was just emerging as a subspecialty, and our knowledge base was very thin. And so we came across this country to say we need to improve the quality of research and clinical care in pediatric emergency in Canada. This group has made important advances in croup, in gastroenteritis, and bronchiolitis that is probably worldwide in its impact, and has really been published in great journals and everything else. There are also a substantial number of other quality publications and highly valued research. We initiated a collaboration with KT Canada in 2007. In 2009, we brought together, we said, well, we're one country. Let's bring together all the pediatric emergency research networks. And so we brought together all the networks under this umbrella called Pediatric Emergency Research Network. And really, what you have there is a knowledge production factory worldwide, and we now have access to that. But you need to take that product and bring it to the point of care, and that's where TREKK. This is a little more about PERN and the fact that it covers has global impact, and we've actually added another network after this slide. And so you would say the research that really matters and is happening in this area, we're networked and connected to it. This is a good way to kind of visualize the way this all ties together. You can see that on one side you have PERK, which involves 15 pediatric EDs across this country, but only 20% of the sick kids. But that's where new knowledge is being created. But you have that new knowledge, and instead it's being used for the 80% of sick kids that are being seen in the general EDs. Now, it really took a small subsection of all the general EDs across the country to kind of create a knowledge mobilization laboratory. And we try to purposely sample small EDs, large in urban areas, remote, up north, in rural areas, to really understand how knowledge gets mobilized in a variety of different venues. And PERK and PERN continue to have this important role in improving the research care within the pediatric emergency department. And it is, you have the different research groups jostling for this is an example of vision rules for head injuries, where on the left you have Dr. Nate Cooperman, who led the American effort through PCARN to develop the PCARN head injury rule. And on the right you have the Canadian lead researcher, Dr. Martin Osmond, who led CT rule for Canada. And they were published in Lancet and CMAJ. And how do you then take this evidence and apply it to the context? And I think the debate and the discussion, this is a picture of us meeting in BAM, really was knowledge contextual. The reason we need a Canadian CT decision rule is we decide who needs a CT, and the US context was deciding who did not need a CT, just the various approaches to practice. So this is the TREKK team. I'm very honored, and really, what I do is probably not that impactful, but it's really the co-directors that have come together and really energized and provided it. You have Dr. Shannon Scott, who's a nursing clinician scientist at the University of Alberta and was an inspirational leader for doing the needs assessment. Also at the University of Alberta, you have Dr. Lisa Hartling, who is also director of the Alberta Research Center for Health Evidence. And Hartling is a PhD-trained physiotherapist by professional background, and she's been the amazing leader leading that synthesizing of the knowledge and ensuring that every condition we identify has a high level evidence. Dr. David Johnson, a pediatric emergency doc at the University of Calgary, who's helped with implementation and has really been a leader in this country, and Dr. Mona Jabour, University of Ottawa. So it's a phenomenal team that we work with. A long history of working together, which really has led to the trust, a high level of being able to really do important things together. And you see, we've explored creative ways that knowledge can be mobilized. In this case, we looked at a randomized controlled trial of storytelling as a communication tool, and was part of Lisa Hartling's PhD thesis. And really saying, you know, we need innovative areas, and it did impact the decision regret that parents had in terms of coming into the emergency department with croup. So, you know, we obviously need to explore further in what format, what's important ingredients to the story and narrative, but it's creative, innovative way to look at knowledge mobilization. And also expanding, Dr. Shannon Scott's had a research program, and Archibald's been her PhD student to look at, in case they were doing a systematic review, not only narrative storytelling, but adding on visual arts-based approaches. So using the right side of the brain as a knowledge mobilization activity. Here we have Dr. Jabour leading the work on best strategies to implement clinical pathways in the emergency setting, and a cluster CT that she's carrying on in the Ontario context to understand how best to implement pathways such as asthma and other common conditions that get treated in these areas. Dr. Janet Kern, who's a nursing scientist at IWK, has been really leading a whole research program around understanding that whole discharge instruction for caregivers and exploring that within the context of pediatric emergency care. And so a really important research question that's been happening there. So that group that really has set the foundation for TREKK to go on. And so, but we did not want to pretend because we're researchers and we, you know, done some study that we knew things. So we really wanted to go into each of these emergencies and understand their needs and preferences for knowledge mobilization. Both care professionals, but also health consumers. So iPad went to every one of these emergencies and had a questionnaire that could easily be filled out and then uploaded, I guess, to a central data repository, which then really gave probably one of the richest needs assessment of how knowledge gets mobilized, what their needs, what are their top priority conditions, how do they want to get the knowledge. You can see we had 32 general EDs, which almost just under 1,500 surveys. It was a 57 response of all possibilities of possible health professionals who could have responded. And we had 897 responses from health consumers. We then enriched this quantitative data set. Dr. Shannon Scott's research group went into select 7 TREKK sites to do focus groups to dig deeper in terms of that exploration of knowledge needs. And you see these were the results. So the nursing profession definitely was the leading part of the responses, but physicians were in there and also allied health professionals. See, when they ask, well, how do you get your health information at work? That desktop computer was still the leading source. But interestingly enough, the smartphone was emerging as a tool, and in the younger generational set, the residents in training seem to like that approach, and they probably live in a smartphone world, and it becomes very natural to them. When you ask, well, how do you get your knowledge? You know, talking to this is one of the most reassuring human slides seen in a long time, that 82% still got their knowledge from talking to colleagues. Not just going to the website, but report, professional development opportunities, the like. Also, what like in the future? And well, we'd like protocols and treatments for common conditions. We want evidence-based information. I'll talk a little more about the clinical conditions they said they wanted. You can see here is the response rate. In red is the 60 to 80%, yellow is 40 to 59%, and green is 20 to 39%. But they asked us for more professional development opportunities, and they wanted this entity called a printed summary, which was not going to be a long, discussion of all the review evidence, and they wanted a bottom line recommendation. Just tell me what to do. So they were believing that we would do that work of ensuring it's the highest level, the most valid evidence, and they would take a very simplified 1 or 2 bottom line summary and use that. So in a busy, chaotic emergency department, they take that to the bedside and know how to treat that next child. when you health consumers, they are looking for information before they come. You can see 4 in 10 look for information before coming to the emergency department. What we're looking for, they wanted to know what the symptoms, what's a barking cough. 43% wanted to know, well, how do I know how bad this is? Like, when do I have to get concerned? So looking some indication of severity. And they were talking to trusted professionals. They did use internet search engines, talk to family and friends, and not as much, at least in this data set, smartphones and apps. So this is our top knowledge. This is what drove our initial prioritization on the knowledge needs, the 14 top priority conditions. So we did use the results from the needs assessment, but we, there may also be unperceived knowledge needs, and so there we went to other sources, such as has this amazing database of when patients get referred to a pediatric hospital. So understanding what are the conditions that generate a referral from a remote hospital to Calgary or Edmonton. We then, the CMPA allowed us to use a database on resolved lawsuits for conditions that had initiated action of a plaintiff or a family, so that we can understand what's generated. I mean, that's obviously a moment of uncertainty and anxiety. So that was another thing that drove the knowledge needs assessment. And then, provinces, some of them also keep a list of a child mortality list. So why are kids dying, and understanding are there preventable deaths? And so from that came this top list. And you can see some things like severe head injury may be common or multi-system trauma, but when it does happen, boy, do you want something to help you with this. And so that drove it. And then you have the common conditions, croup, asthma. So it really gave us rich and allowed us to focus our efforts in creating the knowledge sources. And then, well, how do we share these? How do we share the needs assessment? We've done webinars. We have a slide deck. We visited sites, and we have a 2-page summary if people want to read about that more. And use graphics in terms of trying to put it in a nice, this is how many participates in your site. So this is giving feedback back to a specific site. This is how many your site responded. This is how many people across Canada. This is the site, how long they practice, what's the average length on TREKK. So really trying to give that site-specific feedback. So committee, and we talked about the knowledge needs. So this prioritization was emergency docs working in these EDs, pediatric emergency physicians, and knowledge mobilization experts came together to understand things and really draw that further. So they have the evidence. We would synthesize it online, and that would get put in TREKK. And so we had the Alberta group that, the Center for Health Evidence, that would really, once the prior condition was identified, they'd get the content expert, and they'd drive a high-quality evidence synthesis. If there was a systematic review, they'd use that, an overview of systematic reviews, or they would, do a systematic review. And then that would all then eventually be synthesized down to a user-friendly summary, these bottom line summaries that I've told you about. And so we used this framework of, so you can see a knowledge pyramid, an evidence repository. So at the bottom, we allow people, if you go to our website, you can find the primary research, the critical RCT, and diagnostic and prognostic studies. But then also, we also have systematic reviews and network analysis of primary studies. So that's, a few of those. And then at times there may be evidence-generated clinical practice guidelines, pathways, or decision rules. And then, so if you wanted to go further, but most people wanted the bottom line summaries. But you can have that for, let's say, croup, this is how to treat it, this is what you look for. But if you want to drill deeper down this database, you can do that. Or for practice, you might do this, and then you might go home and explore the practice guide or review that systematic review at a different time. So a very flexible system, and it depends on the knowledge seeker. Like some are very curious, some going to know the bottom line. And our advisors are phenomenal, because they really are, in many cases, the people who first author on the critical study, and also practicing clinicians. So Friedman has done some of the world-breaking work in gastroenteritis. Dave Johnson, your man on croup and asthma. Dr. Sarah Reed has done some work on diabetic ketoacidosis, and so led that work. And Dr. Amy Clint, first author on a New England Journal paper on bronchiolitis, and Dr. Graham Thompson's done work on sepsis. So you can see, staph epilepticus, fractures, concussion, and these are people that are CHR funded and can do hard first presentation. So this national framework of experts really helped drive it, but they were in a committee context also. And then also on severe head injury, Dr. Sue Beno from the Toronto Sick Kids. So a very, amazing group, proceduralization and suction, acute pain, and meningitis. So that is truly incredible to be able to draw on such a wide breadth of expertise and otherwise. So then thirdly, so you get the priority conditions, and now you want to know what are the strategies to really adapt to the local context. Because remember from the needs assessment, there were different ways that people wanted that evidence or strategy to be adapted and to really understand knowledge gets used in different ways. And then also to be iterative in your process. So, you try an approach, and that might work or not work, and then you have to adapt it to a different way. So it's really a learning culture to continue to improve and adapt and try to get the best strategy in this very rich and engaging environment. What we learned is that professional development. So they didn't want just the bottom line summaries. They also wanted learning situations. So we know that in emergency training, just like maybe airline pilots, simulation-based training sessions are critically important as learning a team approach to resuscitation. We conducted that in 4 provinces. But we did face-to-face educational sessions. We did webinars and podcasts have become a very important where we have someone talks to the bottom line or the evidence summary. So we're exploring different ways of trying to put the evidence more than just something that you can download on the website. And you can see the results of that also get people knowing about TREKK, and that 85% of people who attended educational sessions plan to visit at TREKK.ca or even contact TREKK for resources. So it's a way of reinforcing and being available for folks. And toward then is a website. But this allows 24/7 access to evidence-based from emergencies. Don't close down at 5 p.m. They're 24/7, so you need the information. But it's a high-quality information vetted by a TREKK team. We try to, working with Greg Van Mosler, get a responsive web design. We really try to look at, thought redesign, improving efficiency where they exist. And so we hope that it has improved and the usability features have improved, but I think it's still a work in progress and will continue for time to come. This is how the website would look. You can see you see the resources, so you have the evidence repository, and that would provide the peer-reviewed information, like you'd have the bottom line recommendations, but if you could drill deeper and get the clinical practice guidelines, or deeper, the systematic reviews or network analysis, and even deeper, you could the critical randomized trials. And but you can see that you can also on the website have these podcasts, so that we're going to work and you wanted to listen to something about diabetic ketoacidosis, you just put on a podcast and can hear the audio and having the kind of the discussion format, so that are the emergency medicine cases. And there are other tools that also in the next phase we want to really start to work more on information that's for the healthcare consumers. And then more on terms of the diabetic ketoacidosis, the bottom line, and how it looks. here you can click on the other learning tools or podcasts, the Pediatric Emergency Medicine reviews. So we identified all the systematic reviews that we could identify in Cochrane that were relevant to pediatric emergency care. And so it's helpful that way. But this is how a bottom line looks. So this is on diabetic ketoacidosis, which is quite a complex condition, but it's very exemplary of why you need TREKK. So diabetic ketoacidosis in kids is substantially different than in adults. Kids can get cerebral edema, they can coma, they can die. So if you administer fluids at the right rate, it's serious business. And so you can see that, a few helpful hints, how to diagnose it, how to classify it, the mild, the moderate, the severe diabetic ketoacidosis, and what are the important things to look for. Slow fluids, don't give them too fast. Kids will die more commonly of cerebral edema than they will of dehydration from diabetic ketoacidosis. So that's important to use. And then also, which kids really do you need to refer to the definitive tertiary care setting? And you can see this very complex condition, serious, potentially life-threatening, is put on one page, and you can see if we're in a tense situation up in yellow knife, this could be a very helpful tool. Multitrauma, like how in the world do you cover that? So we as people know how to cover trauma. They've done their advanced trauma support course. So this is the pediatric angle, like the fact that there are unique anatomical, physiological, and developmental differences. And so what about the spine control? How do you do the breathing and circulation? And there's a pediatric Glasgow cone scale. So it's contextualizing. We assume as an emergency doc you have a lot of that information. This is to help contextualize it in the care of children. Of course, we are in a bilingual country, and we've gotten a lot of positive feedback that containing these bottom lines in French is an extremely important aspect of what we do and mainly from Quebec, they've been asking us, please keep that up. Do not let that drop from TREKK. Then, the patient family health resources. Now, in our first phase, that is completing at the end of this year, we've not done as much around the family resources, but we see this as a key part of the plank should be reviewed. And so we've been working with a parent advisory group, and they're incredible in terms of providing collaborative opportunity with community parent groups. They've been incredibly helpful in terms of helping us with the website, and they started to develop these interactive storybooks for croup and asthma, and just a ready-made, so-called focus group that can give us information and feedback to really understand how to use narrative in the best way to teach people about high anxiety provoking conditions that they might face at home. And this is building on Dr. Lisa Hartman's PhD work, looking around the croup storybook, and see it helps to explain what croup is, what sound is. It's how to cope. It's a story in the middle of the night, which is usually when it happens. There's a little airway, the narrowing, and where that is. So you do a bit of pictorial with that. And I don't know, does the audio work here? No. So it actually gives you what respiratory distress looks like. And then there's context-specific information. You can see if you're in Manitoba, click on it. If you're in Ontario, there'd be, numbers to call for that. So there's provincialization of the evidence and where to go for that. And then, what to look for in that interactive sense. And then this is Asthma Tool, which is a new one that's just evolving and trying to explain what asthma is, and using the visual. Remember, Dr. Mandy Archibald is the one also using visual arts as part of her thing. And so it's been incredibly useful. So you could ask, well, what has TREKK really, really accomplished to now? I think we've actually, in the Northwest Territories, the TREKK priority conditions have actually been submitted to the Standards Review Committee as part of making that the standard in their region. sites in Alberta and Manitoba, TREKK web logo, and on an ED desktop, there will be the TREKK logo, so easy access in front of you. In British Columbia, which stands for the British Columbia Institute for Technology, they actually train, they have a nursing training course, and they said, well, you have this amazing needs assessment, can we use that to help design our curricula, because we want to know what are the key things that we need to have. We've been very active in participating in local conferences, but Canadian Association of Emergency Physicians, which is the emergency physician group, to us and said, we need you. We want to use, first of all, prioritization of conditions, but then all the content. We want an emergency medicine review course for pediatrics, and so we're creating those slide decks and the audio to go around, and that's part of a CAPE site. Eventually, their emergency docs across the country will go and can use these evolving modules once they're completed, and they're very, very close to completion. With system change, if it applies to equipment and medicine, we get questions around that. We're having 200 downloads a month, and that's climbing every month, and really incredible partnerships that have been happening. But this is an attempt to look at this from a social network analysis. So Dr. Janet Kern understands social network analysis. I don't profess to do so. I worked with a medical student, Jonathan Ripstein, who spent a summer and part of everyone to work on this. So in 2014, we looked at the TREKK network and what impact was it having. So this is kind of the national overall situation. Probably this is a clearer slide in that you can see that according to now, there were 17 isolated sites in 2014, and that's out of the 36, right? So, man, that's a lot of isolated sites, and so what's happening? And then just repeated this analysis in 2015, and we've reduced it now. There are only 3 isolated sites that mean within the context of the social network analysis. And who are the connectors and the communicators there in Canada, and how is this happening? And you could say, well, didn't you interact with all the TREKKs? Yeah, at an administrative level, we went there with iPads, we had our coordinators go there, but if you're a doc or nurse working, you might never really have noticed that. And so the survey that went to the front users, so that is really the impact on this network of the frontline workers in terms of what's happening there. Why do this has been successful? I think to understand the culture, the value, learning, innovation, patient-centeredness, approach face-to-face methods, I think have been very important part of what we made central to TREKK in terms of creating that culture. We try to have supportive leadership with clear roles and a structure. I mean, we're not fixated on our organizational chart, but there is one, and people understand it. With management and communications, you can always improve that, but we attempt to do that. And then routine evaluation, or how are you doing, using focus group meetings and metrics to understand how it's getting out there and improving things. And I think these are some of the key ingredients. The knowledge broker has been a really important role to have, and connecting. And of course, that knowledge broker is Crockett, currently here and located within the Center for Healthcare Innovation in Winnipeg, but she liaises with people across the country. The coordinator at each site, incredibly important. The clinical champions who really drive and understand it, but yet come together in a network context to work with others. Content advisors, again, evidence still drives it, but content advisors to understand the context. Management team and partnerships with a growing number of groups across Canada. So we think we are the only national network that's really aiming at emergency care for children and general ED. So that's a particular niche that we're marketed to. We have amazing, rich data set of knowledge, needs, and preferences, and really focused on trying to improve Emergency Care Canada, and that's the hardest metric to get. And we hope over the next 3 years to improve the metric on patient outcomes, because we have more on the process side of things than actually the situation. We know now that gastroenteritis has an improved outcome. This is what it looks like nationally, and you can see the Perk Sites are the green circles right across this country, and then the TREKK sites are the flags, and so you can see you have 3 to 5 TREKK sites associated with every Perk site across this country. And you know from the social network analysis how these are all weaving together, that sociological phenomena of networking, and that we understand some components of it, but some we're still learning about how it happens. There have been 4 partner organizations that we've been working with, 2 active committee members, and 31 renowned experts in peak emergence that we've been working with. So that's kind of the story as it goes to today. I think it's been a great journey. I think it's good that we have TREKK here today, and the fact that people are coming to us, and it's like we gave samples, but we've also, let's say, North York, Jen came to us, and they're instituting computerized order entry in their emergency department, and they're wondering, we use the TREKK evidence and that to apply to their pediatric orders, so that seems like a great partnership to go on. That's been developing an incredible data set on how to interpret pediatric x-rays. That's Dr. Kathy Budis from Sick Kids and Dr. Martin Pusick from New York. And it's an online repository of images, but using pedagogical principles of the work people through the diet, because their pediatric x-rays are a lot of pitfalls. Let's say the elbow, you can have normal lines that aren't fractures, or you can have very serious fractures that people might miss. And I think we've started a partnership with them to add that onto the TREKK website. So we really hope that our time in Ottawa next week is successful. They have a written proposal for the renewal for the next 3 years, and we then also hope the presentation goes well. And now for the next 2 days, we have a group that we've put together, businesses, people in the banking industry, and others who have given up their time to really look at the sustainability of TREKK, and that's the meeting that I'm running between. So it's the sustainability committee of TREKK. So it's trying to now start to look, well, what after these 3 years? How do you ensure that TREKK becomes a reason to children and family across Canada for the years to come? I think we have good time for questions, and thank you very much for listening. I assume that you've been listening, but
Thanks, Terry. That was lots of information, and that would have been my first question was about sustainability, but I think you answered that, so that's great. I'm go now to the lines from outside and just check, are there any questions from Edmonton?
We don't have questions, thanks.
Okay, thank you. How about Laval?
No question from Laval, thank you very much.
Thank you. And how about McMaster?
We don't have questions here.
Okay, great. And Toronto?
No questions here, thanks.
And how about Halifax?
Go ahead.
Oh. Hi.
Hello. Okay, sorry.
I can hear you now.
Can you okay?
Yeah.
Hello, my name is Margot Latimer with the Aboriginal Children's Hurt and Healing Initiative here at the IWK in Dalhousie. And I was really impressed with the presentation and really interested in learning about the work that's being done in emergency departments. And sort of intrigued because, Terry, you're from Manitoba with the largest population of Aboriginal children, and as we know, the fastest growing demographic across the country. So our work around helping identify what's happening with Aboriginal kids in pain and what's happening when they do come to seek health care. And we learned that we are doing a very good job of actually assessing their pain because the way they express it is different. So I was wondering, and I noticed that in your list of priorities that pain isn't one of them, even though it's probably one of the common reasons for coming to the emergency department. So I wondered within your project, is there something around pain or pain assessment that you're incorporating?
That's a great question, and so it didn't show up necessarily on the quantitative side, but through the unperceived needs and some of the focus groups, it has been appearing as part of it. And so, for instance, procedural sedation, which might be the, be in pain at the highest and the more significant interventions we do for kids, that has appeared as a knowledge synthesis. And then it's coming into the fracture management strategy. Obviously, fractures did appear on our knowledge list of needs, but what is a fracture? I mean, one of the most important things is how to manage pain. So, but we can. I would think. I mean, there are huge swaths of knowledge and things that pain is like tipping the surface, and try to describe how we chose those. But I think for the coming years, it's going to be expanding that and trying to engage other like people like yourself who are creating high little evidence and knowledge, and then think how best to bring you into this as a collaborative relationship with TREKK and ensure that gets covered. And then of course you've touched on a critically important issue, is the whole issue of how now you get the diversity within the emergency departments, and I think the Indigenous health is a really critical one, and one that we live and breathe here within the Manitoba context. And the other thing that we have here is, I think in the next phase we'd like to understand that a bit more, is nursing station, or people who live in remote areas and they might not have what's classically defined as emergency department, and how we start to engage with them around knowledge. And I mean, we lived through that. This is in the papers here, so it's not anything where there was a child who died of sepsis from MRSA, and that child's journey started in a nursing station, and so to understand that, I think there's a lot to be done. We've tried to, take a piece of that. I think the question is really just really illustrated how much work is left to be done, and important, critically important work. And for sure, we hope, if you get renewed and then think of sustainable strategies, those are the things that you'd like to take on in a greater way.
Thanks very much. Are there other questions from Halifax?
No, that's it. Thank you.
Thanks. What about right at Winnipeg site?
In the audience here.
Yeah, it was really interesting talk.
I get close to the mic so everybody can hear them.
Come up to the. Everyone can hear me here. I'll come and join you at the front. Hi. Bring my. I don't know. I'm a singer. I'm a family doc and a clinician researcher, maybe. So the question is actually sort of two parts. One is to follow from what you just said there about the nursing stations. I think primary care has there's sort of a gap there, because a lot of what's considered pediatric emerge often does first present at the primary care level, and there's probably a knowledge gap there. And the other gap that I kind of perceived we were talking, you sort of just touched on at the end about the North York General story, this idea of that the clinicians are using, the younger ones and some of the ones are using smartphones for their email and for Googling, but there's this huge gap between, and then they're downloading a PDF or a face for some knowledge, but the actual clinical systems they use aren't actually having any of this knowledge that's being generated and synthesized and processed well embedded into their actual clinical systems. So I guess the question is really, can you speculate to sort of the future of this sort of integration of knowledge? Do you think that's where things are going, or is there other directions in terms of better targeted educational sessions? But obviously this is an expanding area, so what's the kind of future looking like?
And I don't profess to know that. I think your comments on primary care are totally valid, and I think that's another area that one could spend a lot of time thinking and doing something about. I think what is the future? So building this evidence repository addressing the key conditions. How do we go beyond it being a website and the complex question that I think we're open to exploration. There is someone we've been talking to in Ontario that's developed some form of charting as a structured charting system for emergency departments, and started to ask whether he could work with TREKK, and so that would be a partnership that would be the first way into that. We've been strategic and measured in how we go about this, and I think our product will be a high-quality, relevant evidence tool and product. How then starts to interface with systems and be more generalized, I think something happens through strategic partnerships in the coming years. We know that probably the next phase is thinking of because of health being provincial, even the resource is national. Let's here in Manitoba, we've been talking about the concept of Manitoba TREKK, or TREKK-toba, where all emergency departments are acute healthcare delivery places, and think of how do we best support them. And so in the coming year, we'd like to meet them and start that relationship, and so go beyond the 3 general emergency departments we have today, and think of how we now provincialize or make this more impactful.
Mm-hmm. Yes. Thanks. Yep.
Is that all the questions at the Winnipeg?
No one else is raising their hand or asking a question currently, so yeah, it's good.
Okay. I had more than Terry was. I think that the population, the Indigenous population, has been identified, but the other, there are other groups that we need to consider as well, and I've been actively working to try and have better pain assessment for children with developmental disabilities, and so how we serve children with autism and disabilities in emergency departments is another one that we could obviously have some good conversations about, I think.
Absolutely, no, I agree. And it's through talks like this that often you get 1 or 2 key, potential partnerships. So it's
yeah.
We have a question from the audience.
Good.
Okay. So she said, thank you very much for the fascinating seminar. My question is, if there are any ethical approvals that need to be obtained for performing the KS reviews for clients, or are there any ethical approvals that need to be obtained? And do you need consent from the patient in advance?
Need assessment, we needed to go through ethics and approval. For the synthesis of evidence, i.e., existing stuff out there, we don't, and presumably the primary research studies have always kind of sought their ethics approval when they perform the randomized trial, which is the evidence that we look at. So just to do this synthesis matter review, we haven't been seeking ethics review approval for that.
Thanks.
Is that or were sent in then, Megan?
That was the only one I got from the audience.
Okay, great. Well, if there are questions, then we'll thank you so much, Terry, for that presentation, as well as the stimulation of ideas and potential collaborators. I think it's really important to keep having these conversations.
thank you for the invitation, and it's been great to to be probed in some areas and to reflect on some of that. So thank you.
Thank you from Toronto. Thank you, Dr. Temple and Dr. Klassen, very much for your help.
Our pleasure.
Thank you.